Okay, so we're going to talk acute respiratory failure. There's a lot. There's a lot to unpack. We're going to talk about ABGs. We're going to talk about all the different disease processes. We're going to talk about the nuances of the disease processes. This is going to go on for a fair amount of time. I tried to make this a quick review so that it would be a little bit easier to stomach. So this is only going to be about 30 minutes. But this is a super review of respiratory failure and acute respiratory distress syndrome. Again, this is not a super. This is a super review. This is not a comprehensive review. Super reviews are quick guides. Comprehensive reviews are long and drawn out, and you just want to put me at speed 3, but you can't understand me because I sound like the Micro Machine Man. And that joke was only funny to maybe 5% of you because I'm old and I'm just realizing that. Well, life is unfortunate, but it's cool. So, get through it. It's going to be fine. It's very important information, especially if you have tests coming up really quick that cover these grounds or cover ABGs in any capacity. So, 1, 2, 3, go. Here we go. All right, so acute respiratory failure is nothing more than I didn't get enough oxygen or I wasn't able to ventilate it out, aka I didn't breathe deep enough to push out the CO2, or both, right? So what does it cause? It causes hypoxia, hypoxemia, you can't breathe, right? Decreased PaO2. PaO2 is your ability to give oxygen to your entire body through the arterioles versus SaO2, which is through your lungs, right? So if I have a decrease in PaO2 and a small decrease in SaO2, I am far more concerned with your big decrease in PaO2 as I am in your SaO2. So don't try to get the two confused, okay? So bottom line, I'm not oxygenated and I've got too much CO2. So hypercapnia, I'm breathing too shallow, too much, I'm hyperventilating, I've got all of this carbon dioxide that's just retaining, right? And then increased PaCO2 is again from the inadequate removal. Of course, you're going to have a bigger CO2 because you're retaining it. So all you got to do is push it off. ABG is going to be your gold standard test. That is absolutely going to be on your exam. Go ahead and write it down. Gold standard for confirming acute respiratory failure is ABGs, always. Now, acute respiratory failure is not a disease, right? All it is it reflects the current lung function. So acute respiratory failure is acute, and then it's not going to be a diagnosis code you're going to have later on in life, okay? One or more disorders involving the lungs or body systems. So yeah, cardiac system is going to be affected, respiratory system. So it's got to meet this criteria. That's all that the slide's saying. So what this says is that there is a problem with hypoxemia versus hypercapnia, the disease process is going to be different. So you're only going to get a respiratory or a cardiac issue when relating to hypooxygenation, right? Hypoischemic changes is because we don't have enough oxygen in the cell, and the only two places it passes through is the heart and the lungs. So that's why it's only exclusive to those two systems. Now, hypercapnia can be from my brain because there's a tumor or a hemorrhage pushing on that area. It could be from having COPD and I just don't have a good enough ventilation to kick out the CO2. Yes, what she just said. It could also be neuromuscular if I have a degenerative disorder that inhibits my ability to take a nice breath, right? Like cerebral palsy is a good one. I can't think of what the one that needs cystic fibrosis. I was like, it needs a polycarpine ionophorosis test. Yeah, cystic fibrosis. So those are going to attack from a neuromuscular system process. So just that's all that's saying in between the two. So this says hypercapnic respiratory failure. All you need to know is, hey, guess what? It's called ventilatory failure or hypercapnic failure because hypercapnia means you're breathing too much, which means you're holding in too much CO2. And hypo or hypoxia, all that means is your arterial blood in that exchange is reflective of your SaO2. So PaCO2 is ventilation or hypercapnic respiratory failure, whereas PaO2 is hypoxic respiratory failure, and that's all that means. So you can have acute on chronic respiratory failure. Acute meaning that you have an exacerbation of it. So what's pretty normal is if you have COPD exacerbation and you go into acute respiratory failure as a result of that. So it's a little bit worse than it normally is, and it's never really good. So it is, yes, that's how I feel about it too. So basically, chronic means you have stable changes over time versus acute, which means you got a big problem, you got to get it fixed immediately. That's all this says. All right, so all this slide says is there's 4 physiologic mechanisms. So what is the physiologic mechanism? It basically means why is there good function or dysfunction, and what might cause this. So in this case, what is the dysfunction and why? So there's 4 reasons and dysfunctions that would cause us to be in this hypoxic respiratory failure, okay? Mismatch between ventilation and perfusion, or your VQ mismatch, okay? A shunt, diffusion limitation, alveolar hypoventilation. That's it. And the most common is through the shunt phase. So I'm going to go over all of these one by one. So just commit them to memory and know that the most common is shunt. And you might see that in your exam. I wouldn't be surprised if that was a question. All right, the only thing you need to know for this slide, the ventilation perfusion mismatch, is the normal alveolar ventilation is 4 to 6 liters per minute. And all that means is my ability to inspire and go, that means I'm getting the equivalent of you putting a nasal cannula on me and giving me 4 to 6 liters of oxygen to sustain my body. That's average for a person, okay? So that's all this stuff really means on the rest of this page. I don't want you to get too hyper-focused on these pieces because these pieces will confuse you, and this is over the level of your scope right this second. So again, COPD, most common diseases that are caused by VQ mismatch or perfusion issues. So asthma, pneumonia, COPD, these work directly with the alveoli themselves, which is why ventilation and perfusion are a big deal, which is why we always see these 3 commonly associated. So you might have a question that says a disease or condition that might cause VQ mismatch would be select all that apply. COPD, pneumonia, asthma, done. So then how do we fix hypoxemic respiratory failure? Well, it's simple. Turn it around. So if you have a PaO2 that was at the wrong level of exchange, then reverse it. Usually done by creating and figuring out what the underlying cause is, treating the underlying cause, and then you just go back to normal function. So that's basically all this slide says is, hey, guess what? The first thing we're going to do is try to fix it. And then we're going to turn it around to its original state. Yeah, that's profound. Let's put that in a slide. That's what this means. So consequences of hypoxemia. So this is a big one. If you are hypoxic, that means you have inadequate oxygenation. So what happens is while these are going from bad to worse, if they're severe enough, the cells go from aerobic, which is with oxygen, to anaerobic, which is without oxygen. So basically, these cells run on no oxygen, and they increase your lactic acid, which causes metabolic acidosis. If it isn't fixed with bicarbonate, then you get tissue cell dysfunction, and then you die. Like you die dead. Like you died real dead, kind of die. So please understand, hypoxemia is a big deal. Those cells will go from aerobic to anaerobic, so from oxygenation to no oxygen, and then it'll increase the lactic acid and cause metabolic acidosis. So this is why when we get patients with acid-base imbalances, whenever we see metabolic acidosis, we go, oh crap, because that's the one that really scares us. Because we've got to fix it immediately and turn it around, or they could quite literally die. So all this slide says, which with a lot of big words, is it says, hey, manifestations of this, signs and symptoms of this happening, is a sudden or gradual onset. So it can happen all at once, or it can happen over time. Well, no dip, Sherlock. Most things are that way, right? A sudden decrease in PaO2, which is our oxygenation, right? Or a rapid increase of PaCO2, which is our hypercapnia issue, right? It implies serious condition or life-threatening emergency. Well, no dip. Of course it does. If someone can't breathe, and if someone's got too much CO2 in their brain and it's noxious to the brain and in their system and in their lungs, yeah, that's how that works. Yeah, for sure. So signs of respiratory failure are related to the extent of changes, right? So it's related to how bad it was, how fast it happened, and how well the patient's going to be able to compensate. I feel like, why are we even making a slide about this stuff? I think that's a big fat waste of time. So I'm just going to go ahead and stop talking right now. All right, I know this is going to be on your test, so make sure that you know this slide. Decreased oxygen affects all body systems, sure. Manifestations may be specific or non-specific, of course. First signs of respiratory failure is a change in mental status. Know that a first sign in respiratory failure is a change in mental status. Now know that if you have a decrease in oxygen, you're going to be restless, confused, and agitated. That's only for oxygen. So you can still have respiratory failure, have a change in mental status, and then it be decreased oxygen is causing the problem because you're restless, confused, and agitated. Now, if it is a CO2 problem, it will cause you to have a morning headache, decreased respiration rate, decreased level of consciousness. So that morning headache is really a big change. Also, decreased level of consciousness does not mean confusion. Please understand that. Decreased level of consciousness is, I don't really know where I'm at, but I can tell you my name and date of birth and how many kids I have, okay? Whereas confused means I don't even know who I am, right? If that makes any sense at all. So make sure you know the difference between what does it mean to have decreased oxygen, what are your signs? What about CO2, what are those signs? And then what are the first signs of respiratory failure? And now I've got to go put a little kid in the corner, so give me just a second. All right, now true hypoxemia is going to give you these signs and symptoms. Please note that it says the SpO2 is less than 80%. Otherwise, it's just a deoxygenation, not true hypoxemia. So, chest expansion, abdominal movement, skeletal muscle retractions, all the things that we always hear about. Other signs are just central nervous system, agitated, confused, combative, restless, delirium, exhaustion, just pure fatigue. You can't talk through a sentence. That's all this says. Just know that those are non-specific signs of hypoxemia. So again, notice we're separating hypoxemia or low oxygen or PaO2. This is going to be one category, and then we're doing hypercapnia again, associated with too high of CO2 levels, and they're being separated into groups. So this is probably going to be a question. So like I said, know these signs and symptoms. Respiratory, let's see, hypercapnia, dyspnea, obviously, because that's what causes the hypercapnia. Tripod position, because that's the only way you can breathe when you have hypercapnia. Pursed lip breathing, because again, you can't take a breath, so you're doing it that way. Decreased respiration rate, which is why we're hypercapnic. Rapid rate with shallow respirations, again, because we can't push out the CO2. Like, you see where I'm getting at here. It should be pretty self-explanatory, because if you just walk through it, you'll know that the problem with it is, hypercapnia caused the issue. And then here are the non-specific signs, which I don't think you need to even memorize. Just look over them, kind of understand the concept, and move along. All right, so manifestations of this, early signs, your heart and your lungs try to compensate by messing with your numbers, by increasing your heart rate, by decreasing your respiration rate, so that we could change the way your body is reflective of these ABG changes, right? So if your PaO2 is less than 45, remember 60 is what we're looking for or above. If you are not getting adequate PaO2, then you are not getting adequate feeding of your entire body system, right? So you need immediate assessment, and you have to potentially intubate, give emergency respirators, whatever you need to do to get them back to baseline. So here's all the things you need to look for. Tripod position is going to be probably the most comfortable position for them. It's pretty common. Obviously, you'll look for slow respiration rate, which is going to give us hypercapnia, or rapid shallow from fatigue, which is hypoxemia. That's all the slide says. So again, find out if they're able to speak more than a couple of words. Look for pursed lip breathing. Look for the intercostal spaces retracting. Look for the use of accessory muscles, the paradoxal breathing, right? They could be sweaty because of the increased work of breathing. That's all this says. I remember seeing the slide in the guide notes, I think. I'm pretty sure. So I want you to remember when you auscultate breath sounds and you hear fine crackles, that's going to mean that the patient has pulmonary edema. I'm going to need for you to know that when you auscultate breath sounds and you get coarse crackles, there's fluid in the airway, right? Which is why they're coarse crackles, because there's things bubbling through it, which is why it gives a crackling sound, right? Um, Absent or diminished, you know that's atelectasis. Ain't nothing moving, right? Pneumonia, hypoventilation. You're not breathing well enough, so it just dies, right? So no bronchial. If you hear bronchials, then it's consolidation. If you hear pleural friction rub, you know it's pneumonia involving the pleura. Sorry, I have a small child currently stepping on my head, trying to get past me. Sorry. Could you stop? Please? No, stop. I love you too, but it's annoying. All right, next slide. All right, so most common to figure all these things out is chest x-ray. Number 2 would be ABG or pulse ox that's continuous. And here's the other derivatives that we use as well. That's all the slide says. All right, I've deleted like 3 slides that said, hey, we want patients who aren't going to choke to death. So make sure that you understand our goal is to get their airway better. And I didn't feel like that was necessary to spend 3 slides talking to you about, so I got rid of them. So make sure that you're getting a thorough history and assessment. Make sure that you're doing deep breathing and coughing with them. You're doing incentive spirometry, and that you are talking about early ambulation. That might be a question on your exam. That's a pretty common point that comes around a lot in tests. In order to prevent, pneumonia, atelectasis, and things like that. So you need to know that what you need to educate them with, and then what it's going to prevent, and then you should be good to move on. So I don't want you to look at all this other stuff down below where it says oxygen therapy. Graze over it, but it's going to confuse you. Just know that this slide means that the respiratory therapy goals are to get the correct acid-base imbalance and to maintain adequate oxygenation ventilation. That's it. All right, these will be important as well. Respiratory therapy and oxygen therapy. Patients to be able to tolerate it, and we need to maintain a PaO2 between 55 to 60, and then SaO2 at 90 or above. Okay, so this whole slide is talking about FiO2. FiO2 is the amount of oxygen gas that is in your crisp, clean oxygen, like the concentration of it, okay? So the higher the concentration of oxygen you get, the higher chance you get of oxygen toxicity. Now, I know that sounds really crazy to imagine the fact that if you've got too much oxygen, you could have a toxic amount of oxygen. But guess what? It's the thing. So you're going to get absorption atelectasis. You're going to get increased capillary permeability because you are hyperoxygenated to the hilt. Remember, you will get sick if you have a COPD patient who has 100% oxygen, because we can over-oxygenate a person and put them in just as bad of a shape as if they haven't had any oxygen. So, sorry, I have to go. Okay, almost done. So make sure that you understand increased pulmonary capillary permeability means that if you barely even touch me, my fingers are already cherry red, I'm already blanching, okay? And this is going to be a big problem. So make sure that we're addressing that issue immediately. So when we're dealing with a COPDer that has hypercapnia, you really need to ventilate them. They need to get on a BiPAP or a CPAP so that they can kick that stuff off. Most of the time it's a BiPAP, because if a CPAP was going to work, it would have worked before. A lot of time they can't put it on CPAP mode because most people are non-compliant. So just know that BiPAP, CPAP, those are your standard modalities of kicking off the CO2 so we can put our patient back at baseline. And of course we need to make sure we have stable secretions so they're not blocking any airway. So this is how we do it. This is how we need to position a patient. Head of bed 30 degrees, reclining chair or bed. Decreased dyspnea. Use side lying position to prevent aspiration, right? Lateral sidelining for good lungs to improve your VQ matching. Yep, that's all right. So just make sure that you understand those concepts. Head of bed at 30 degrees, I believe I recall seeing on your guided notes, by the way. All right, this talks about augmented coughing or quad coughing. Just read the definition and understand the definition, and understand that it has something to do with quad coughing so that we can clear secretions. All right, that's it. And here is the literal definition as well as a guided imagery so that you can understand how this works. just know the difference between huff coughing and stage coughing. This is a huff cough is when we do the to try to get something out of the central airway. That's all that is. And then a stage cough is, this meditative coughing and deep breathing exercise. So just know which one's which. So chest physiotherapy is nothing more than patting the back like you would pat a kid when they're, eating or trying to get some phlegm out or whatever. Percussion is, that's percussion. Vibration is going to be a jiggle jacket. So it's a jacket that you attach to a machine, and it just shakes really, really vigorously, and it does the same thing as percussion does. Or you have the classic postural drainage, but you don't really get to break anything up. All you get to do is just shift those fluids from one area to another. All right, so this just talks about the PPV, the positive pressure ventilation. It talks about the two types, CPAP and BiPAP. Know what the different levels do. Know that the CPAP is continuous positive airway pressure versus BiPAP, which is bi-level positive airway pressure. BiPAP is recommended for kicking off CO2 a lot easier because you can increase the level of intensity, whereas the CPAP you cannot, and that's basically the difference. And here's a picture of the CPAP and what it looks like. Alright, so a lot of times we can reduce airway inflammation and bronchospasm just by doing corticosteroids and bronchodilators. That takes care of the problem, so we don't have to intubate. If we have pulmonary congestion, like you hear those coarse crackles, then we have IV diuretics. We've got morphine to slow down our work of breathing and give a better breath. That's why we give patients morphine, not to kill them, but to slow down their work of breathing so that they can get a good tidal volume breath. And then, of course, nitro as well. All right. You got to get with a nutritionalist to maintain protein and energy stores. If they're in a hypermetabolic state, you need to start enteral parenteral nutrition fairly quick. So this is all that this slide says. All right, so I'm gonna help you walk through this. So again, we're separating hypoxemic respiratory failure from hypercapnic respiratory failure. So we're doing it again. Which patient is a high risk for hypoxemic respiratory failure? A patient who has respiratory muscle paralysis. Nope, respiratory muscles mean if I have paralysis, I'm not getting a good breath. That is a CO2 problem, not an O2 problem. So therefore, that is not the answer because this is a hypoxemic, not a hypercapnia. So a patient who has fractured ribs and a flail chest, same deal. If I fractured a rib, which I've done many times from boxing, it hurts like the dickens, so I'm not breathing in deep. So I am increasing my CO2 stores. So again, I am not hypoxemic, I am hypercapnic. Patient who has massive pulmonary embolism. Now this one's interesting. Pulmonary embolism means that there is an occlusion or an obstruction, right? So this means I am losing my oxygen flow. So that's going to be my answer, I can tell you right now. Let's look at D. Patient who has slow breathing from a drug overdose. Again, we have slow breathing, slow respirations, which means we're not getting our proper ventilation, which means we're not pushing out CO2, which means we have too much CO2, which means we're hypercapnic, right? That's how that works. And let's see if we're right. Yup, we're right. So there you go. All right, so if you have acute respiratory failure and then you have a sudden progression of that form, then you turn into acute respiratory distress syndrome or ARDS. So this is one step worse. So what happens in ARDS is basically all of your alveoli, or those sacs or balloons that make up your lung tissue. Stop it. Stop stepping on my computer. Dang it, girl. I swear, your need for attention just goes beyond anything I've ever seen. And I stay on top of you. Sorry, I had to reprimand a little small baby who's cute and currently smiling at me. So, alveolar capillary membrane, it becomes damaged and permeable to intravascular fluid. So what does that mean? Well, intravascular fluid is a fluid that's between your tissues and such. And what happens is the capillary membrane, it becomes weak, right? And then it starts busting holes in it. And if it busts holes in it, that intravascular fluid could go into it. So then all your alveoli that's supposed to contain all of your oxygen so you can breathe is now full of fluid. That's basically how that works. All right, so all this shows is where the interstitial fluid goes into the alveoli and how it kind of gets trapped in there. So that's what it looks like for this to happen. So predisposing factors to ARDS, number one, most common cause, sepsis. Know that. Also these other things. So read that. So these are obviously the three phases. Your injury or exudative phase is where we have the interstitial fluid going into the alveolar cap. So that's the initial injury that causes the acute respiratory distress. Then we go into the proliferative phase where we try to repair itself. And then we have the fibrotic or fibroproliferative phase, which is when we start to have some pretty nasty clotting issues. So usually if you get to the fibrotic phase, you don't make it. Usually if you're in the first two, you have a good chance. If you're in one, obviously you're the best chance. So yeah, it says here, survival chances are poor. They're going to need long-term mechanical ventilation. That's true. Sometimes they need it for months. And then we have the different stages of injury. So just read over this and understand it. So now we're getting into stages. So we need to understand that the initial presentation is within 24 to 72 hours. And these are my symptoms, okay? So don't commit a whole bunch of this to memory. Just understand the concept. So if they're 24 to 72 hours, and it is what they call the initial phase, so everything else is going to be initial, right? So their symptoms are going to be very, very mild. They're going to have fine scattered crackles versus coarse versus stridor versus, other stuff. Their ABGs are going to be mild, all right? Their chest x-ray might show a little bit. So that's the whole concept of this. And then obviously as the ARDS progresses, our symptoms get worse. So we start to have increased work of breathing. We start to have respiratory distress, all the things that you would expect. So you're going to hear an ARDS progression. You're going to hear the coarse crackles with expiration, not inspiration, expiration. Your chest x-ray is going to show this, and your ABGs are going to do this. So just keep that in mind. So again, we've got numbers and we've got different parts and pieces. So ARDS progression, severity of the hypoxemia, we're going to have greater than 200, less or equal to 300 is mild, and then moderate and severe. And you calculate it by your PaO2 divided by your FiO2. Are you going to have one of these? For MedSurg 2, I would certainly hope not, but just memorize calculation just in case. So your cause of death for all of this is multi-organ dysfunction system, or MODS. So yeah, that's what happens. And just read that and understand it. So yeah, this just says, hey, this is the end stages of things getting worse. So here's what happens next. So abnormal lung function and complications, patient will recover in 6 months if they do make it. All right, VAP, big deal. Ventilator-associated pneumonia. We talk about VAPs all the time in hospitals. VAPs are going to be on your NCLEX. VAPs are going to be on your standardized tests, okay? So it's a big deal because it does all of these things, and it can be fixed very easily. So the problem with VAP is people get ventilated-acquired pneumonia because people don't brush their teeth while they're on a ventilation device. So we'll talk about that in a second. And again, here's how we prevent this. Good hand hygiene, elevate the head of the bed 30 to 45 degrees, wash with chlorhexidine, da-da-da-da-da. So barotrauma is any time that we get those alveolar sacs, or those balloons that create our lung tissue, and we basically pop them. So these are the reasons that happens. And then you would want to ventilate with smaller tidal volumes, because obviously the force and the tidal volume you're giving them is blowing up those alveolar sacs and bursting them, and all you're doing is collapsing a lung. So one of the issues we have when we're talking about barotrauma and ARDS and ventilation is we also have thromboembolism that happens all the time because we keep them immobile, right? And a lot of times we can't get to them to turn them every 2 hours as much as we'd like to. So please understand that compression stockings are absolute necessity, anticoagulants absolute necessity, and early ambulation if you can get them off the ventilator fast enough. So if the problem is we don't have enough oxygen, what happens is oxygen is taken from the entire body and thrown into the lungs to keep the lungs at bay so that the body doesn't die, right? Because if the lungs die, the body dies, and the body's pretty selfish. So what it does is it takes the oxygen from the kidneys and then it shunts it over to the heart so that it can pump, and then it can be oxygenated, blah, 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 blah. So this is why we're going to have this decreased renal perfusion and this renal failure. So you got to monitor your intake and output, make sure you understand your BUN and creatinine and what that means. So just keep that in mind, that we're stealing oxygen from everywhere we can. So if the problem is we don't have enough oxygen, what happens is oxygen is taken from the entire body and thrown into the lungs to keep the lungs at bay so that the body doesn't die, right? Because if the lungs die, the body dies, and the body's pretty selfish. So what it does is it takes the oxygen from the kidneys and then it shunts it over to the heart so that it can pump, and then it can be oxygenated, blah, 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 blah. So this is why we're going to have this decreased renal perfusion and this renal failure. So you got to monitor your intake and output, make sure you understand your BUN and creatinine and what that means. So just keep that in mind, that we're stealing oxygen from everywhere we can. Obviously, if you are a survivor of ARDS, you have basically had the equivalent of being shot in the chest twice and then lived to tell the tale. Because it's that jarring to the body system, and you basically drown to death and then bleed to death over a period of days, but not before you go into complete organ failure. While you're basically semi-conscious through the entire process and well aware of what's going on around you, but can't do anything to fix it. So these are the problems they're going to have as a result of that. That's all the slide says. So if the problem is we don't have enough oxygen, what happens is oxygen is taken from the entire body and thrown into the lungs to keep the lungs at bay so that the body doesn't die, right? Because if the lungs die, the body dies, and the body's pretty selfish. So what it does is it takes the oxygen from the kidneys and then it shunts it over to the heart so that it can pump, and then it can be oxygenated, blah, 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 blah. So this is why we're going to have this decreased renal perfusion and this renal failure. So you got to monitor your intake and output, make sure you understand your BUN and creatinine and what that means. So just keep that in mind, that we're stealing oxygen from everywhere we can. So when we're dealing with ARDS, some nursing diagnoses are impaired gas exchange. Duh. It's ARDS. It's acute respiratory distress syndrome. Yeah, that makes sense. Impaired respiratory system function. Yep, got that one too. All right, next slide. Again, know your PaO2 needs to be 60 or higher, and your PaO2 needs to also be looked at in conjunction with your SaO2, which should be greater than 90%. All right, so over the years we've gotten pretty creative on how we fix ARDS. And these are some of the ways we do it. I hope we get to slide over ECMO, because ECMO is kind of a cool procedure. And the rest of the stuff is just stuff we do on mechanical ventilation. Alright, all this slide says is that oxygen administration can be done through BiPAP that delivers oxygen. Yep, we're aware. You need to constantly monitor your oxygen. Yep, got that. And then mechanically ventilate with FiO2 to keep PaO2 at least at 60. Short layman's terms, in order to keep the person breathing, we need to get their arterial oxygen up, and it needs to be at least at 60. And we're using pure oxygen to do that. That's all this says. This slide basically translates to, hey, don't blow up the person's lungs or they're going to pop like a balloon and they'll die. Yeah. Yep, that's exactly what this slide says. Alright, all this says is that they use low tidal volume ventilation to try to not overwork the alveoli and make them burst, and that's all that this says. So very rarely when we're dealing with someone who's got a brain trauma or increased intracranial pressure, we will do what's called permissive hypercapnia, and that means I'm going to let someone's CO2 be high by way of putting in low tidal volumes. Now this patient is mechanically ventilated. This patient is being told how many breaths to breathe based off of how we have wired this machine to pump out the oxygen and the pressure, all right? So in the case of traumatic brain injuries or intracranial pressure changes that are too high, you want to have a lower tidal volume. Let me explain. So when you have lower tidal volumes, you set your body at an easier state. And remember, we don't care if we're getting a whole bunch of CO2 because we're already knocked out. I'm on propofol. I'm on the Michael Jackson drug. I am laying there. I've had a car accident. I'm near death. I'm about to die, but not quite. And this person is trying to make me breathe for myself to determine if I'm going to be able to make it out or not. Okay, this is the type of situation we're in. So I will decrease their tidal volume and make their lungs not have to push themselves so hard to get a big breath in. And as a result of this, it is going to maintain my ABGs. So I'm going to have a normal pH, and I am going to compensate gradually. So my brain is going to be oxygenated, and that oxygenation will increase gradually, which will increase my ability to receive my brain function that I lost back and maybe come back to this world. That's kind of how that works. Are you going to be tested on that? Ugh, I don't see how you would, because that's a pretty hard concept to follow. But just understand the cycle and understand the concept, and you should be good. All right, so I don't want you to get too hung up on PEEP, because PEEP and things of this nature are never mechanically managed by you. This is going to be mechanically managed by your respiratory therapist. But just so you know, there are a couple of types of PEEP. There's also a couple of issues related to PEEP. So it depends on if you're an auto PEEP or if you need to overcome something. So here's basically how it goes. So in auto PEEP, air is trapped. Okay, so in auto PEEP, the alveoli, they remain inflated at the end of the expiration due to obstruction. So the alveolar pressure is greater than the atmospheric pressure. And what does that mean? Well, what that means is it's keeping it in a state of autopilot of inflation, I guess is the best way to put that. Okay, and then we have external PEEP, and that treats, well, auto PEEP if I'm honest. So basically, positive PEEP pressure of the external PEEP eases the amount of work in the diaphragm, and it must draw air in order to do that. Okay, so external PEEP keeps it from, brings in external air from the external surface versus being constantly open by way of that positive pressure. There's a slight difference. Now, auto PEEP is going to increase the work of breathing because it's going to have to overcome that positive pressure during the inspiration. And the diaphragm must energize or generate enough negative pressure to exceed the auto PEEP. So basically, external PEEP versus auto PEEP. One, the alveoli remain inflated. That's with auto PEEP, right? And then external PEEP that treats the auto PEEP. That would be, if that goes awry, the positive pressure of the external PEEP will ease the amount of work to the diaphragm. Basically, that's all gobbledygook, and all you need to know is PEEP is positive in expiratory pressure, done. Respiratory is going to manage this, done. This isn't something that you need to be concerned with, done, unless you see some really gnarly signs and symptoms, and if they go blue, it's bad, all right? And if the alarms are going off, go get a respiratory therapist. Don't just hit the silence button that remains on for 2 minutes and then things go awry. So I don't want to confuse you too much with PEEP, even at the very tippity top of the NCLEX ready to take it level, because again, this is not something that we manage at all. This is something we have to know, because back in the day as nurses, that was a thing. It's no longer a thing because we're smart enough to know that we can't do all things at once. Most of us are smart enough. So, all right, let's go to the next slide. All right, during COVID, you heard of people blowing out their lungs, quote unquote. This was something that would happen in the ICU when we had lungs that were basically frozen. So in the very, very beginning, we didn't know what to do. So if I'm quite honest with you, it was a lot of trial and error and checking medical records, and sometimes our protocols were changing hourly. You got to remember, I was there at the drop of everything. And I never left my post until the biggest concern then became staffing nurses. So then I switched roles so that I could, get a staffed nationwide and do what I can on my side, on my part, to advocate for that, and then get back on the field, right? So here's phase 2 of what that looks like, which is getting you guys, back where we need to go. So when we're talking about PEEP, you're not going to mess with this. I've already said this 15,000 times. What you need to know is what the definition of PEEP is. What does it do, right? It increases the pressures. so that you can do that. Now, what's the problem with that is when we were playing games like we were doing, trying to figure out how to stop this stuff, we were increasing the PEEP thinking that we had more lung space, but we didn't, because this stuff was like molasses in January to your lungs. It would freeze up things. So we would be pushing, trying to open a space, and then we would bloop, pop them. And that was the problem, is barotrauma or volutrauma. So that's all you need to know, is that we don't want to increase the PEEP so much so that we overinflate things and cause that type of barotrauma, because it will absolutely kill a person. But again, remember, as rough as this sounds, this person was already going to die, and we didn't have any other options. And we had already talked to the family about the options that we chose, and the options that we chose were going to be very slim, and they agreed to those things. So please keep all of that in mind when I'm telling you these stories and you think we're just manhandling life and it's martial law. Back in that day, guys, it was martial law. Just FYI, we were all on our own. I'm not, like, I wish I could joke with you about these things, but I'm not. Dude, the things that I used for PPE, you would not even believe. It's ridiculous. So when you hear me, when the passion comes out of my voice and you think I'm yelling at you, I'm not. I'm recalling that moment in my head, and I'm playing it in my heads-up display of my brain. And I'm doing it as I'm speaking to you so that I could be literally in that moment. Because remember, the fun part about having a squirrely brain is I can do that, right? It's all stored in my library. So I just access it as I'm speaking about it. And I'm feeling those feelings again. And I need for you to feel those emotions, because you can feel those emotions with me. And I need for you to understand what that space is if you can't be in that space yourself. And I hope to God you never are. Because you want to talk about a moment of desperation and there's just nowhere to go, and the only person that's there is you. And that's it. And residents are looking at you like, what now? And we're all sitting at a round table like King Arthur going, I don't know, can we try colchicine? Hey, look, there's something here about colchicine. You want to give it a go? Yeah, let's do it. Just order for everybody. Sure, go, do it. Like, that was our reality. Those were the conversations we had daily, hourly. That's insane. That's insane. Think about that for a second. All right, and then when you're done, go to the next slide. Let's get done with this. I'm starting to get those feelings I don't like. The machine is still moving, so here we go. All right, this is exactly how ARDS works. So acute respiratory distress syndrome. That's when fluid basically just pulls into the lungs. And then when they lay down flat, it's like they have CHF, only worse. So it pushes down all that fluid. It pushes down when they lay down on their heart, on their lungs. It makes it easy for them to get atelectasis because it's pushing down, so it can't get a good breath enough for it to stretch and do its thing. And those muscles aren't doing that full body tidal volume breath that it needs. So it gets lazy because you're choking. And then, of course, your PaO2 goes down because that's the concentration, right? And if it's laying down on our chest and we can't breathe, then we're not circulating. If we're not circulating, we don't have enough oxygen to get everywhere. If we don't have that, then we start having, trauma, and we become deoxygenated and confused because we can't get enough oxygen to our brain, and that's that. Prone usually fixes this problem because when we stick them in a prone position, what it does is it backs that fluid off and allows it to stop pushing all that pressure on the mediastinal, area. So that's that. Let's go to the next slide. And again, in this slide, what we're going to do is we are effectively getting all of that into the back of the lungs. We're shifting that fluid to the front. And what's going to happen is there's going to be an insurgence of fluid. So we might need to suction this person more often. They're going to be coughing up stuff more often. That's the whole plan of this, right? Like, this is what we want. We're trying to do this so that we can reduce the PEEP, because we don't want to mechanically ventilate those alveoli. We would prefer it if you were able to do it on your own. So we will slowly decrease it, and we will put you in a prone position for a few hours so that you can get used to breathing again. And that's the theory. However, in COVID, the second we started putting you in prone, and the second those kidneys started shutting down, we basically knew it was over. If I'm 100% honest, that was kind of it. That was kind of the moment. So keep these things in mind. This isn't the end-all be-all fix. This rarely works. But when you have a patient who maybe isn't, the first generation of COVID, it's going to work a little bit differently for them. So things like jiggle jackets are also super important when we're talking about things that we're going to do in addition to some type of mechanical ventilation. And keep in mind, this isn't just being, tubed. This is other forms of mechanical ventilation that still, BiPAP, CPAP, that still helps free flow and force air into those areas and spaces so that you can get a good breath. Next slide. So as soon as we have a confirmation of ARDS, the first thing we want to do is throw them into prone so that we can go ahead and start giving them the back of their lungs so they can use that more effectively for breath. Respiratory therapy is going to be needed, obviously. Making sure that the airway is secure. You need to get these guys a yank hour or yonkers, what you guys call it, but it's pronounced yank hour. If you got a yank hour and you gave it to them and they were mobile, they could use it themselves in between all of that, or you could do serious suction. We don't like to do nasotracheal suction when we have these types of patients. Why? Well, it's super effective, sure. And I get that they're full of fluid and we need to get that out, sure. However, what am I doing when I do that every time? I am scratching the internal tissues that have never been touched by human hands, except for when you pick your nose. But even beyond that, there you go. And I'm shredding it, thus causing inflammation, thus swelling your throat. So that's super cool if I already have you in a state of having a lower PaO2, right? Yeah, no. So we try to discourage that. So what we try to do is incentive spirometry instead, right? We will do jiggle jackets. We'll do whatever we can to break it up. Mucinex. We'll do the whole gambit trying to get you to cough this junk up so that we can get out of this critical state. So next slide. So this is an ECMO. An ECMO is considered a life support system. I'd say so. So when a person is critical or there's organ failure or anything like that's going on that prevents the lungs from providing enough oxygen to the body or the heart or pumping enough blood, whatever the situation is, this mechanism will increase survivability of this patient by a little above 50%, okay? You could have this support for up to 30 days, but usually it's not continued beyond that limit. So what it does is it helps your body recover by being like a secondary set of lungs. All right, this is kind of, not even the same thing as an iron lung, but it's like a second cousin of an iron lung. How about that? What you need to know about it, this person's super sensitive. They could tank at any time. You're in an ICU at this point. You're in a lot of trouble. So making sure that all of your blood gases are appropriate is the main concern for this patient. In the history of me reading all of these questions that I have read, I've never seen anything specific to an ECMO procedure other than identifying that this is a life support mechanism for up to 30 days for a patient who has whatever type of organ failure that is also attacking the lungs and causing dysfunction that is so bad that it is a problem with life sustainment. Okay, there you go. All right, next slide. So what are we going to do? How are we going to check this patient? Well, it's pretty simple. If we are in acute respiratory distress system or syndrome, I am looking for every daggone thing wrong with them specific to heart rate, respiratory rate, blood pressure, mean arterial pressure, right? SpO2. All of these things are my CO2 levels. All of these are going to be absolutely important because I am expecting this person to go through what? Respiratory acidosis. Why? Okay, listen, first off, this is acute respiratory distress syndrome. Respiratory anything, alkalosis or acidosis, is only ever going to be respiratory, right? Anything else beyond respiratory is going to be metabolic as far as arterial blood gases are concerned. So we have acute respiratory distress syndrome, and if I have issues with my CO2 because I am potentiating problems with that, then I'm going to more than likely be in a state of acidosis because I have respiratory distress. Okay, therefore I have increased CO2 levels. See how that works? So anything that is a respiratory distress issue, be it COPD, be it, asthma, be it, emphysema, things of that nature, pneumonia, all of these are going to potentiate exacerbation and then ABG disturbances that are going to be reflective of respiratory acidosis. Done. Period, point, paragraph. All right, moving on. Again, I have never in my life seen a question about kinetic therapy. I've never in my life seen a question about lateral rotation therapy. However, I will tell you about this. So what happens is it's a tilt bed. So every 15 minutes, it literally gives you a click of a turn. Or you can stick it on different rotations. You can actually set it to like 1 hour, 2 hours, whatever. These are the super fancy beds that we love that cost a ridiculous amount of money and break more often than they work. It's kind of like my interpretation of the McDonald's ice cream machine, right? That's what that is. So we have them, we love them. They're constantly getting fixed. Maintenance is on speed dial, but yeah, they do. They tilt you so that you can properly oxygenate, you can properly circulate your tissues, all of the things, right? And kinetic therapy is basically a little bit more of a swing than that. But yeah, that's the gist of it. I really have nothing else to give you because I don't really think this is going to be NCLEX worthy of any further explanation. So, all right, next slide. All right, so sometimes we have to give medications to settle a person. When they're in exacerbation, I need for those lungs to quiet down, and we do that using lots of medications. Sometimes we use morphine because it takes care of the pain of the chest from, the ridiculous amounts of issues related to, those muscles in between the ribs giving us problems, between the coughing and the internal, jostling and movement, like that's painful, et cetera, et cetera, et cetera. Plus fluid accumulation is very painful, blah, 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 blah. So when we're talking about this, if we reduce the pain, we also reduce the response, which means we get a better work of breathing. So a lot of times we'll give them something to sedate them and keep them calm. Or if they have like an ETT tube, and we have them, mechanically ventilated, the traditional way of thinking of it, then that person, obviously, we're going to have them knocked out. We usually put those guys on propofol, where we're knocking them out dead cold, right? And the second I see them move, I'm cranking her up, and that's cool. That's perfectly copacetic because we get that. So that's all I have for that, basically, because I think the concept's been relayed. So next slide. So what are we doing with oxygenation and support? Well, we're watching everything because we have to make sure the heart's working. So we have to monitor blood pressure. We have to make sure the brain's working. So mean arterial pressure. We have to make sure that it is oxygenated but not poorly oxygenated. So we got to check CO2 levels, right? We have to check for fluids. We have to make sure that we don't have any drugs on the mark that are going to make it worse, right? We're checking every angle of this person. We're checking the tissue perfusion, right? Because obviously the lungs are going to be the reason that everything stays oxygenated and working appropriately. So I think that's pretty self-explanatory. I'm just going to move to the next slide. Obviously, when we're laying in the bed and we've been intubated for a week and a half, what happens is we're laying stagnant. So those fluids kind of move around and shift around in weird ways, and sometimes they just stay in certain spots, right? So we have to do daily weights. We have to do eyes and nose. Why do we have to do this? Because there's fluid kind of floating around everywhere. We're trying to get it out. We're trying to pull it out. More things are creeping in. We're trying to get those lungs going well and listening to them often. So this is kind of what we have to watch out for. And we do parenteral nutrition 24 hours to 48 hours after if we're going to have this type of patient, because we know that if I am spending that much time struggling to breathe, I'm not going to get this person to eat, period. So the assumption is go ahead and start feeding their body now, because as they're feeding and supplementing their body, they're not going to get immunosuppressed on top of everything else. Simple as that. Makes sense, right? Because nursing is what? Common sense. All right, next slide. Again, this is a silly question, but I've seen these silly questions on NCLEXs. I've seen them on Capstone. I've seen them on standardized tests. Expected outcomes for a patient. Maintaining a patent airway. Duh. They have acute respiratory distress syndrome. That's a big deal. Making sure we have adequate ABGs. I just talked about respiratory acidosis and what that means. Making sure that they have normal hemodynamic status. So what does that mean? That means making sure that they have a state of homeostasis and that they're not dying. That's super cool. So yeah, that's it for that slide, and we'll move on to the next one. So I'm going to attempt to work out this problem using the 7 principles. I hope that you've seen the 7 principles lecture. If you have not seen the 7 principles lecture, none of this is going to make any sense. So watch the 7 principles lecture, because this is a hack to the algorithm to every single nursing exam you've ever taken. No. Yes, dude. I've been screaming about this for a month and a half. I've been teaching these classes for nearly 6 months. My results work. Okay. My method works. I've got statistical data to back that thing up. Okay. It's a big, fine woman when I back that thing up. I'm just telling you. My results are a big, fat woman, and she's quite beautiful. So let's walk on down the road with her. I'm just saying. All right, a patient's ABG results include pH of 7.31. All right, here's what I'm already thinking in my brain. 7.31, I know that's low. I know this person's in respiratory acidosis. I don't care what's going on. I know they got ARDS. We're done. All right, PaCO2 is 50. Yikes. All right, cool. PaO2 is 51. Okay, things are going bad. HCO3 is 24. I'm not complaining about that. All right, cool. And the patient is placed on high Fowler's position. An hour later, here we go. Repeat is 7.36. All right, we're normalized. All right, cool. PaCO2 is 40. All right. PaO2 is 60. All right, we're levelized. Cool. HCO3 is 24. 22 to 26 is normal. That's good too. Fun fact. Your pH is 7.35 to 7.45. Your CO2 is literally 3.5 to 4.5. That just makes life easier for you. So in this case, I know that this person is level. However, this little buddy right here, which is our little guy right here that I'm going to underline, we're at 40. We're slightly higher, so we're partially compensated, but we're not fully compensated. So in this case, what we're going to want to do is crank this little bad boy up because we can handle it. Why? Because this is normal. Why? Because this is cool. Why? Because really the only thing that's leveled off is this little buddy, and my pH is returned. And what does that mean? What that means is I'm not getting quite enough oxygen. So I crank her up and I'm good. Documenting the findings on the patient, we wouldn't want to document that because we still have a problem. So we still have things we have to fix, so we're not fully done. Reposition the patient back in a semi-Fowler's position. Well, what's that going to do? That's going to put more pressure on us, so that's a no-no. Prepare the patient for endotracheal intubation and mechanical ventilation. Dude, you should have done that before if you were so concerned about it. Duh. So all that is left is this. All right. One of these things is not like the other. One of these things does not belong. How can I look at this and see if this is a thing? All right. Prepare the patient for ET suction. That's ridiculous. Reposition the patient. That's going to make it worse. Document the findings. That's going to make it worse. All right, cool. All three things of this delay care or make this patient worse, and it's unnecessary. These are unnecessary situations, yo. That's that. So then A is going to be our answer, and that's that. And let's move on because I honestly don't know if I'm right or not. I tell you what, still cold-blooded. So A is the answer, and that's awesome. Let's do another one. Okay, so when assessing a patient with sepsis, okay, which finding would alert the nurse at the onset of acute respiratory distress syndrome, okay? SpO2 of 80, no. No, not necessarily, although that's pretty bad. Why haven't we done something? A lot of things can cause a temporary SpO2 of 80. That's curious. Let me think about that for a second. All right. Use of accessory muscles of respiration. That's not necessarily ARDS. Fine scattered crackles and auscultation of the chest. Acute respiratory distress system. Acute is the word I'm looking for here. I was looking at A, but A is not the answer because this would be not acute unless they threw a PE. I want to say it's C. I want to say it's C because the onset is our key right here. That's our trigger word. And this would be the earliest situation right here versus the others. So I'm going to go C, and I hope I'm right. This D, I'm not hating on because everything looks fine and stable, so they wouldn't have a problem. Yeah, I'm going to go with a clean. All right, C is my final answer. Let's see if I'm right. Y'all, one of these days I'm going to get this wrong, and it's going to be super embarrassing. And if you think I'm going to edit it out, I'm not. I'm totally going to leave it in if I get one wrong. And it's probably going to have to do with BUN because I just hate BUN. Just watch the renal lecture. I just go off on BUN. And then here's the funny part. The funny part was in one of the NCLEX questions I was reviewing probably a month ago, the answer was BUN. And I was like, I literally said no one cares ever about BUN. And in a hospital setting, that's true. But in test world, apparently it's not. So I left in that I screwed up on BUN, and it's cool. I'll tell you again. I made and talked mad trash and gave mad shade to the size of needing an umbrella for it on BUN. And one question of the 10,000 I looked at had BUN as an answer. So there, you win. All right, next question. All right, a patient with severe chronic lung disease. All right, cool. Is hospitalized with respiratory distress. All right, so acute. Acute on chronic. Which finding would suggest that the nurse that the patient is developing rapid decompensation? Rapid, not slow. Remember, this person has a chronic condition, severe chronic condition. Severe chronic condition. All right. So an SpO2 of 86, nah, they live in that. I don't care about that. A blood pH of 7.33, nah, not really, because that would be normal for them. PaCO2 increases from 48 to 55. Who cares? These guys have CO2s of like 80 and they're still talking normal. I'm being honest with you. I've never seen anything like it in my life. That's an exaggeration. 80s, they're pretty confused at 80. But they're still pretty with it for 80 is if I'm honest. They usually don't start getting pretty nasty until you get like 84, 85, 86. And then even that varies. I've seen someone with 102 before and they were still talking to me, so that's crazy. So all that's left here is onset of agitation. And here's the trigger word to give you the answer to the question. Onset. Rapid. See how that works? Boom. All right, so one of these things is not like the other. One of these things is not belong. This is chronic, 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 chronic. And then literally the answer is squat interface with the word onset. Boom. C's my answer. Final discussion. I'm not even worried about it. And again, using the principle, one of these things is not like the other, one of these things does not belong, we can clearly deduce that the answer is C. All right, that's it. I love you. I'm proud of you guys. I am proud of you for getting through all these ridiculous amounts of slides, and I will be throwing down some more here in a bit.